just wanted to identify the problem of hypoglycemia, review the counter-regulatory mechanisms to hypoglycemia and the effect that diabetes has on these hormones, discuss the neurological sequelae of hypoglycemia, mostly in epidemiologic data, and the postulated mechanisms of why this occurs, and then discuss the optimal treatment and strategies to prevent hypoglycemia in our patients with diabetes. So, definition of hypoglycemia, as a reminder, is typically meeting Whipple's triad, so symptoms of hypoglycemia with documented hypoglycemia. There's no fixed level, but in patients who do not have diabetes, we typically say somewhere less than 3. Some sources will say less than 2.5 or 2.8, and then resolution of these symptoms with glucose. It's important to note that in patients with diabetes who have hypoglycemia awareness, they may not meet the first criteria, so Whipple's triad is usually used in patients who do not have diabetes with a diagnosis of hypoglycemia. The main causes of hypoglycemia, so in patients with diabetes, far and away the main cause is exogenous insulin and insulin secretagogues. But as mentioned, change in their current status, so renal failure, some other sort of organ failure, an infection, or alcohol intake can all exacerbate their normal treatment and normal response to their home insulin doses. Patients without diabetes, some causes of insulinoma include, some causes of hypoglycemia include insulinoma, so a tumor that secretes insulin, exogenous insulin use, so patients who are using insulin who shouldn't be, or who are using secretagogues when they shouldn't be. Sometimes we see patients abusing these medications that they've gotten either from a family member or otherwise. Reactive hypoglycemia can occur after a meal. It can sometimes be the earliest sign of pancreatic dysfunction and herald a diagnosis of diabetes, especially in response to a high carbohydrate meal. Non-insulinoma pancreatogenous hyperinsulinemia is a state that we typically see in conjunction with rapid and significant weight loss in our patients who have had bariatric surgery, who have had pancreatic hypertrophy in the setting of obesity and insulin resistance, where they've increased their insulin production to overcome the resistance, but they have a rapid weight loss. You restore insulin sensitivity, but the pancreas is still putting out too much insulin, and then that results in hypoglycemia. Diabetes and hypoglycemia is a very complicated issue because iatrogenic hypoglycemia is a limiting factor in how well we can manage diabetes. It causes recurrent morbidity in most people with type 1 diabetes and many with advanced type 2 diabetes, especially those on insulin, and can be fatal. It impairs defenses against subsequent falling plasma glucose concentration, and that leads to a vicious cycle of recurrent hypoglycemia that we'll talk about a bit more. It precludes the maintenance of euglycemia over a lifetime of diabetes, and therefore experiencing the full benefits of glycemic control for our patients with diabetes becomes difficult. The two organizations that we use for our guidelines at home include the American Diabetes Association and the Canadian Diabetes Association. They both define or break down hypoglycemia a bit differently, but both agree that severe hypoglycemia, which is mostly what we're talking about here today, is when an individual has an episode of hypoglycemia and requires assistance of another person. There's no number cutoff, but typically that's less than 2.8 when that occurs. The counter-regulatory hormones that are involved in restoration of a euglycemic state when a patient has a low blood sugar include insulin, glucagon, catecholamines, acetylcholine, cortisol, and growth hormone. I mention insulin because it's not just the presence of the other hormones, but it's actually having a low insulin level that's very important. So as our blood sugar drops, so in everybody with a normal physiology, as our glucose levels drop to somewhere around 4.4 to 4.7, you have reduced stimulation of the beta cell and you have reduced release of insulin. This is important because if insulin levels are high, you lack these benefits. So you need low insulin levels to facilitate mobilization of energy from existing stores, to increase hepatic enzymes involved in ketogenesis and gluconeogenesis, to increase the enzymes in the renal cortex for gluconeogenesis, because although it contributes a much less significant amount, the kidney actually contributes to gluconeogenesis as well. And then presence of low insulin also prevents muscles from consuming circulating glucose, so that you can have it in the serum to protect the brain. Glucagon is our most acute hormone response, and typically glucagon levels start to increase when our serum glucose is around 3.6 to 3.9. It's regulated by a number of different factors. So the alpha cells have glucokinase and potassium ATP channels, which sense low glucose levels and secrete glucagon in response. It's also controlled by paracrine mechanisms, where low insulin levels also stimulate the release of glucagon. And then neuronal mechanisms, although less contributory, may affect it as well. So direct sympathetic innervation and circulating levels of catecholamines may stimulate the release of glucagon. The result is direct glycogenolysis and facilitating gluconeogenic enzymes in the liver, but not the kidney. Catecholamines are a major backup system, so although glucagon responds first, catecholamines do most of the work. They stimulate alpha and beta adrenergic receptors, and this gives us our symptoms of hypoglycemia, which then tells the patient that they need to eat. It also causes mobilization of muscle glycogen and free fatty acids from adipocytes. They also bind to the beta-2 receptors at the liver, and that leads to an upregulation of glycogenolysis, so breaking down of glycogen to have more glucose in the bloodstream. Acetylcholine is also important. It's released at parasympathetic nerve endings. It acts on vagal and sweat glands, and that promotes the symptoms of hunger and diaphoresis, which are also signals that you need to take in exogenous glucose. Cortisol and growth hormone are less contributory, although, as we mentioned previously, considering adrenal insufficiency in your differential diagnosis for hypoglycemia is important. So the low levels of glucose are sensed in the brain. This leads to a cascade of signaling involving the hypothalamic pituitary axis, and you get release of cortisol and IGF-1. Cortisol facilitates lipolysis, it actively promotes protein metabolism, and it promotes gluconeogenesis at the liver, which we know because we see in our patients with Cushing's having high blood glucose levels. Growth hormone competes with insulin to bind to muscle cells, prevents glucose uptake, and is a direct activator of lipolysis. Together, these hormones lead to our symptoms. So our neurogenic or autonomic symptoms are trembling, palpitations, sweating, which is acetylcholine, anxiety, hunger, again, which is acetylcholine, nausea, and tingling. These symptoms all tell the patient, I need to get glucose into the body. Our neuroglycopenic symptoms include difficulty concentrating, confusion, weakness, drowsiness, vision changes, difficulty speaking, headache, and dizziness, and we'll talk a bit more about these in our patient. These symptoms typically appear at a glucose level of about 3 millimoles per liter, or just over 50 milligrams per deciliter, but as we talked about before, you can see those hormones start acting sooner, but typically people feel symptoms around 3 millimoles per liter. This schematic kind of pulls together all of those hormones and shows how together they lead to restoration of increased glucose. So if you have decreased glucose, that's sensed by the pancreas, you have a decrease in your insulin and an increase in your glucagon. Together, these act at the liver to increase your glucose production, and overall you have an increase of glucose. The brain also senses a low level of glucose. You have an increase in your acetylcholine and your norepinephrine and your sympathoadrenal outflow, so you get epinephrine release from your adrenal medulla as well. Together, these cause symptoms that lead to ingestion of carbohydrates. They also prevent muscle from taking up glucose, and they allow for increase in lactate, amino acids, and glycerol into the bloodstream to be used as substrates for energy. Altogether, this leads to an increase in glucose. In diabetes, those hormones don't work as well as they should. One of the reasons is because in the presence of high insulin levels, your body is relying on how quickly you can break that insulin down and clear it, which is why renal failure is one of the precipitants of hypoglycemia. With the high levels of insulin present, you also have a reduced secretion of glucagon, and glucagon is our first line defense and our first defense, so if you have less glucagon, then you're going to have a less robust response to hypoglycemia. Catecholamines are also attenuated in patients with diabetes, which we'll look at in the next slide. As a result, these patients are 25 times more likely to have hypoglycemia. Hypoglycemia-associated autonomic failure is something that's been recognized in our patients with diabetes, and typically you have an attenuated sympathoadrenal response to hypoglycemia, which is most commonly caused by recurrent episodes of hypoglycemia, but also contributed to by sleep or prior exercise, both of which can lead to hypoglycemia. Sleep because you're not eating, prior exercise because you're increasing your sensitivity to insulin. There's been a number of hypotheses of how this happens. The two main ones are the systemic mediator hypotheses and the brain fuel transport hypothesis. The systemic mediator hypothesis proposes that when you have episodes of hypoglycemia, the body releases cortisol as a result. And over time, the presence of the cortisol makes the brain less robust or less sensitive to the falling glucose levels. The second one, the brain fuel transport hypothesis, is a bit better study, and basically it postulates that in times of low serum glucose, the brain becomes better at absorbing the glucose from the serum. So it upregulates its GLUT4 transporters and is able to extract more glucose from the blood. Then when you have a recurrent episode of hypoglycemia, the brain is still very able to take that glucose out of the blood, so it doesn't respond as well, and then your body does not have the adrenaline release, it doesn't have the acetylcholine release, and you don't have those symptoms to correct the hypoglycemia. So you don't become symptomatic until you start to have the symptoms of neuroglycopenia, which we've talked about before, including headache, and even as bad as coma. This is just summarized in this slide showing that advanced type 2 diabetes and type 1 have relative or mild, moderate, absolute therapeutic hyperinsulinemia, leads to falling glucose levels, but you don't have the decrease in insulin and the increase in glucagon that you would with normal physiology. You have episodes of hypoglycemia, which are attenuated by exercise and sleep, leading to an attenuated sympathoadrenal response. With less sympathetic and adrenomedullary responses, you have decreased glucose counterregulation and recurrent hypoglycemia. So the brain is very important because even though it accounts for only 2% of our body weight, it actually uses 25% of the body's glucose because of the high metabolic rate. And it requires a continuous supply of glucose and has very limited stores of glycogen. It has about 0.5 to 1.5 or 0.1% of the total brain weight as glycogen. And it can really only function normally for a very limited duration with that glycogen. The brain can use ketone bodies during starvation, but they can't meet all the metabolic needs of the brain, which is why the brain is so significantly affected in cases of hypoglycemia. The areas that are most affected include the temporal lobes, hippocampus, basal ganglia, and substantia nigra, and then more specifically some of the smaller structures including spiculum, small and medium-sized caudate neurons, area CA1 of the hippocampus, and the dentate gyrus. This has been evaluated looking at patients with hypoglycemia and doing metabolic MRI studies to see which areas seem to be most affected. As a reminder, temporal lobes are involved in the processing of sensory input into meaning, and the hippocampus is required for consolidation of memory from short-term to long-term. The basal ganglia controls voluntary motor movements and procedural learning, and substantia nigra is important in reward and movement. So the neurological sequelae of hypoglycemia, so one of the early studies in this was in 1985, where they looked at patients who had presented with hypoglycemia and tried to identify what symptoms they had. So you can see here that the majority of patients seem to have depressed sensorium, so coma, stupor, or confusion. This coma typically occurred at about 1 millimole per liter, and the other symptoms had higher glucose levels. The most common cause of these symptoms was diabetes, but you can see here that diabetes and alcohol, sepsis and diabetes were causes as well, which means you should look for other factors or other behaviors or what else is going on in your patient that may be contributing to a change in their baseline. Of these patients, 4 of them had residual neurologic deficits following their discharge from hospital. So 2 who had presented in coma, left with paresis, more so upper extremities and lower. Somebody presenting with paresis, left with residual paresis, and another gentleman who presented with hemiparesis, left with hyperreflexia. So although a minority of patients have residual effects, it is possible. In another study looking at patients with insulinoma who had recurrent hypoglycemia, you can see that the most common symptoms were confusion and coma. Seizure or other symptoms are usually less common. In the more recent study that came out on this, they looked at 388 patients who presented to emergency with hypoglycemia in 2009 in a hospital in Sweden, and they stratified based on level of hypoglycemia, and they found obviously that the more hypoglycemic you are, the more of a chance of having neurologic symptoms. So 25% of patients who had a sugar less than 2 had symptoms. The majority of those had coma, with only a few having seizure. Hemiparesis excuse me, is a known but uncommon presentation of hypoglycemia, first described in 1928. It's typically, the symptom onset is during sleep, or they wake up at night with hemiparesis, typically right-sided, and they often resolve after the administration of dextrose. And here you can see transient abnormalities in the internal capsule and the corpus callosum. I bring this up because our patient, as she recovered, had weakness that seemed to be more right-sided than left-sided, but her motor improved and was similar bilaterally prior to discharge, and it was something we had discussed as a team because, of course, as you're treating a patient, your differential is ongoing and evolving, and we were worried about stroke with seemingly weakness on one side or the other, but it has been described in hypoglycemia as well. 2 other case reports found bilateral chorea and embolism in a patient who had type 1 diabetes for DKA, but his sugar wasn't followed as closely as possible. He experienced hypoglycemia and developed chorea type movement. And another patient also with type 1 diabetes, whose sugar wasn't managed appropriately, ended up with locked-in syndrome, which is when you have tetraplegia, inability to talk, but you're fully awake and you can only communicate by blinking. The mechanism by which the brain mediates coma or survives during a time of hypoglycemia, since it has very low glycogen, is by using other means of substrate. So typically glucose comes in. A lot of this takes place in the astrocytes, where it's converted to lactate and then enters Krebs cycle as pyruvate. However, in times of hypoglycemia, it's been shown that there's a lot of extracellular glutamate present, and that glutamate can actually feed into the Krebs cycle for production of energy in order to maintain a low amount of function of those cells during neuroglycopenia. However, the presence of glutamate, or even using glutamate as a substrate, causes an increase in aspartate. Aspartate and glutamate are both excitatory neurotransmitters, and when they bind to postsynaptic neurons, that causes the influx of zinc. It causes creation of reactive oxygen species, and if that overwhelms the neuron's ability to handle reactive oxygen species, then it can lead to neuronal cell death. So these are the proposed mechanisms by which the brain conserves its energy during hypoglycemia, and why patients are able to recover. So prevention and treatment of hypoglycemia is obviously quite important. For patients with diabetes, the risk factors that have been identified for having severe hypoglycemia is the previous episode. Currently a low A1C of less than 6%. Those that don't experience the symptoms of hypoglycemia because they won't realize they're low until it's too late. A long duration of insulin therapy, autonomic neuropathy, low economic status and inability to access food, low health literacy, cognitive impairment, and younger children and adolescents. 15 grams of glucose is required to produce an increase of about 2 millimoles per liter in about 20 minutes. Examples of 15 grams of glucose or carbohydrate include glucose tablets, 3 teaspoons of sugar in water, 3/4 of a cup of juice, 6 lifesavers, or 1 tablespoon of honey. 20 grams of glucose would increase your blood glucose by about 3.6 over 45 minutes. Milk and juice are slower to increase blood glucose as opposed to actual sugar tablets. And glucagon, 1 milligram, can increase the blood glucose from anywhere to 3 to 12 within 60 minutes. And this is impaired in patients who have had alcohol drinks or who have hepatic disease. So again, looking for those types of things in patients with persistent or severe hypoglycemia is important. So mild to moderate hypoglycemia should be treated with 15 grams of carbohydrate. Severe hypoglycemia, if the patient can respond, should take at least 20 grams of carbohydrate. You should be testing your sugar every 15 minutes until it's above 4. If the patient is unconscious, then typically we give a milligram of glucagon subcutaneously or IM. If they have IV access, D50W is important. So I know the concern of thrombophlebitis was brought up, but coma from hypoglycemia outweighs the risk of thrombophlebitis. So obviously precautions to minimize that with flushing, but if that's your choice, go with the D50. And then once the hypoglycemia has reversed, patient needs to eat a full meal. Optimizing diabetes management. Sulfonylureas obviously are the most associated with hypoglycemia because their mechanism of action is to increase your insulin. Long-acting basal analogs compared to your intermediate-acting seem to reduce total and symptomatic hypoglycemia. The use of rapid-acting as opposed to regular also improves or reduces hypoglycemia. In patients who have type 2 diabetes who have failed oral therapy, coming back to one of the earlier questions, obviously the next step would be to add a basal insulin and to avoid the addition of rapid-acting insulins or mixed insulins as long as you can keep their A1C less than 7% on a mixture of oral agents and basal insulin. But obviously, when you're constrained, that's not always the easiest thing to do. And then for patients with type 1 diabetes, looking at insulin pump versus injections, there has not been shown to be a benefit in prevention of hypoglycemia. So the take-home messages from today that we really wanted to communicate is that hypoglycemia is a limiting factor in optimal treatment of patients with type 1 diabetes and those with advanced type 2. The counter-regulatory hormone responses to hypoglycemia that help us all out when we need, when we can't get to lunch right away, those are attenuated in our patients with diabetes and can increase the risk of severe hypoglycemia. Neurological symptoms, including coma and confusion, may occur. Other types of findings are more rare. They should be evaluated for alternative causes of neurologic symptoms, especially if they persist after you've restored the patient to euglycemia, which is the condition with our patient where we restored euglycemia, she persisted to have a low level of consciousness, perhaps a unilateral weakness. So we proceeded with a CT scan to rule out structural causes. Appropriate treatment of hypoglycemia should be performed if suspected, so even if you can't test the patient, if you think they have hypoglycemia, you should treat them. And then reducing the use of sulfonylureas and intermediate-acting insulin, or optimizing that, may help to reduce the risk of hypoglycemia in patients.